Welcome to the Praxis discussion series. I'm Auskar Surbakti. I'd like to welcome our audience here in Sydney, those watching on APAC, online and listening on radio, and those watching in Honiara, Dili and Port Moresby, and listening in from Kiribati. A new public health crisis is emerging. Non-Communicable Diseases, or NCDs, that were once considered a challenge primarily to the developed world, are now on the rise in the developing world. As it stands, NCDs like diabetes and heart disease kill more than 36 million people each year. Disturbingly, most of those deaths occur in low and middle-income countries. To cite an alarming prediction by the World Bank, deaths from NCDs as a share of total deaths are projected to rise by more than 50% in these countries by 2030. The Pacific is one of the hardest hit regions, with the World Health Organization estimating that 3/4 of all adult deaths last year were due to NCDs. In less than 2 decades, cancer rates are projected to surge by 82% in lower income countries, and the rate of diabetes is growing so rapidly in the Pacific island states of Kiribati, Marshall Islands, Nauru and Tuvalu that by 2030 they're predicted to be 4 of the 5 countries with the highest rates of diabetes in the world. Now, it all makes for some very sobering news, but is there anything that can be done to reverse the disturbing trend around non-communicable diseases in the developing world? How can health systems in these countries deal with the rise in NCDs with resources already strained? Is there a glimmer of hope in all this, or a silver bullet to avert a systemic health crisis? Well, to discuss this, we're joined by Ian Anderson from Ian Anderson Economics, which specialises in the economics and financing of maternal and child health. Dr. Jimmie Rodgers, the Director General of the Secretariat of the Pacific Community, and Dr. Temo Waqanivalu from the World Health Organization's Representative Office in the South Pacific. Gentlemen, thank you for joining us today. Now, Dr. Temo, if I could call on you first, can you paint us a picture? What are NCDs? How big of an issue are they? And why is it such a problem?
Thank you, Auskar. The big main 4 non-communicable diseases are diabetes, heart disease, cancer, and chronic respiratory diseases. But these are more or less the NCD endpoints, let me say. You've stated right, 75 to 80% of Pacific deaths is due to NCD. So 8 out of every 10 deaths in an extended family in the Pacific, be assured it's going to be due to one of these diseases. And the rates are alarming. Diabetes, we potentially have the highest rate of diabetes in the world at the moment from one of the countries. 40% and more of people in the 25 to 64-year-olds have diabetes. Cancer, you've actually mentioned. Most of the deaths, if you go to any health system in the Pacific, the leading cause of death is cardiovascular disease. So 75 to 80% of those deaths. If you look at the disability caused by NCD, 1 in every 10 diabetic would have an amputation. Usually begins with a toe amputation, a forefoot, below knee, above knee, gets to the other limb, and that seems to be the progress. Diabetic cataract retinopathy is still the biggest cause of adult blindness in the Pacific. You got the figures from the ophthalmologists, 30% of those who have diabetes already have near blindness sort of retinopathy. And when you talk about debilitating diseases in terms of kidney failures, those are just immense as far as disability is concerned. On the risk factor level, we got figures like 60% or more of men in Kiribati smoke cigarettes. You got figures like 95% of the adult population in certain countries are either overweight or obese. 80% of the population actually take less than the recommended 5 servings of fruits and vegetables, and more than 50% are not really physically active. So at every level, from risk factors to intermediate risk factors of disease in terms of obesity, diabetes, and high blood pressure, into the NCD endpoints, which are those main 4, we've got huge problem. I met a man in the streets in Kiribati or Marshall Islands he was being wheeled around by his grandson. And I asked the son, why are you at school? He says, no. Why? I have to take care of my grandfather, who's got bilateral amputations, by the way. He's got near blindness in terms of sight. So the impact that it has on the individual and the family is huge. When you talk about cost, and Ian is probably going to speak to that further, 75 to 80%, you go into any hospital, any health facility in the Pacific, you can almost be assured 75 to 80% of adult admissions, of general surgery, renal dialysis units, is all due to non-communicable disease. A disease that is highly preventable by far. And so this is the reason why it has been declared a crisis in the Pacific, not only at the health level. Jimmie is going to talk more on the economic and development part of it. So much about that bleak situation. I think the solutions are also there, and WHO together with the World Economic Forum have come up with what is called the best buys. If there are 3-5 things that the Pacific could do to resolve the issue, what would they be? And so for tobacco, for diet, physical activity, alcohol harm reduction, and the health system for that matter, we've got a prioritized list. And one of the challenges we've had in the past is that we've done so much, yet we haven't progressed and we've achieved so little. So the need to actually focus. For example, in the last meeting in Auckland last year on the NCD forum, the Pacific agreed that if there's only 3 things to do, is to get tobacco out of the countries. If you do nothing else but just implement the Framework Convention on Tobacco Control and get the Pacific to be tobacco free, you're probably heading in some great direction. Salt reduction in addition to fruits and vegetables promotion, because of the high rates of high blood pressure and cardiovascular disease for that matter. If that could be done, we could make some great impact. And then the access to cardiovascular counseling and drug treatment, going more on a total risk rather than an absolute risk approach. And this is the challenge we've had with the health system per se. At the global level and at the regional level, there's been declaration, there's political will, there's political commitment. But when you look within the country and ask the question, how are the sectors responding to the NCD crisis? WHO has been working particularly with the health system. And when we look into the health system, their orientation and their position in order to respond to the NCD crisis needs to be improved. And one of the challenges and we keep mentioning that if NCD is declared a crisis, we cannot just do business as usual, beginning with the health system. And I think a great example that I've always mentioned is when you go up to the very primary health care and you talk to a nurse there, she's going to probably tell you everything about an immunization schedule. He's going to be very good at it. But you start engaging in an NCD discussion, you'll find there's a lot of gaps and a lot of improvement that's needed. So a health system that is still more or less communicable disease oriented, when the burden clearly and declared at political level has been the NCD, and yet the health system is still oriented towards a communicable disease focus.
So, Dr. Temo, you've painted quite an alarming picture, I guess, of the situation in the Pacific around NCDs. Is the big challenge for you and the WHO, is it to instill this sense of urgency within governments to address this issue?
Yeah, and sense of urgency needs to be happening at the government level, political level, but even at every sector, and we've challenged every sector, beginning with health in itself is one of the challenges we've laid with them. Why should you go into a health center and not find a sphygmomanometer to measure blood pressure? I have a discussion with a health assistant in FSM, and I looked around and I couldn't even find a scale. And I asked him, do you have a scale? He said, no. I said, how do you measure BMI and all that stuff? He looked up with the most chookies of ways, looked at me, smiled and said, I just look at them when they come in through the door. And I'm telling the NCD coordinator, I'm not getting this. We declared a crisis, it's a real big burden, but you don't have a scale or a glucometer at the primary health care level. And that's the sense of urgency that we need to bring. Because I was telling you, you need not just have one, you should have two working ones at the health center level, because it's the main burden, and health needs to wake up to the call and begin to address them.
I think this is a good point to bring Dr. Jimmie Rodgers into the discussion now. When we think of disease, we immediately think of health, that we think it's a health problem, but you have a different view on it, don't you?
Yeah, well, NCDs is a disease. But when we actually have a look at what causes NCDs, most of it exists outside the health sector. And I think there are some basic things that we probably need to look at. And I mean, I'd want to focus on where we have come from, where we are now, and where we're headed in this discussion in my next few minutes. Where have we come from? I'll just take a 40-year time span. 40 years ago, population of the Pacific, Richard Taylor's here, so I'm a little bit cautious in this one, is less than 5 million people. 40 years later, we're 10 million people. 35 years' time, we're going to be 15 million people in the Pacific. Well, that's probably still smaller than Bangkok population. But then 40 years ago, NCDs was not an issue in the Pacific. And 40 years later, it is the leading killer in the Pacific. We talk about percentages, and I think it's useful to put those into context. 70 to 80%. That's a very good percentage, but how does that translate into figures? And I think in the next 15 years, there will be 1 million Pacific Island people that would have died from NCDs if nothing changes. In the next 10 years, I'd say 1 million Pacific Islanders will die from all health causes. And I think that's a frightening statistics, and frightening because there is no other cause of death in the Pacific that will match it. Frightening because when we actually have a look at other development priorities like climate change, a lot of money, billions of dollars is going into climate change. It's a long-term issue, but in the next 15 years, it's not going to kill 1 million people. So I think there is an issue here that leads me to believe that yes, NCD ultimately has a health issue, but it is a developmental challenge. It is a much broader socio-economic, cultural, political development challenge, and that's where part of the solution needs to come from. And I think really, for me, the key message is what is the acceptable level of risk? How many people need to die before governments take up the responsibility to say, this disease is killing the population, my voters for the next election are going to die, and therefore I won't get into parliament. I guess I'm talking more here of bringing the urgency out of the health sector into the leadership in these countries and having a buy-in that will then show the way that each country, with the help of WHO, there are many good technologies happening. The health sector is doing its best, but it's not able to make the breakthroughs because go outside the health sector into public services, which controls number of positions in countries. The public service department will say you only need this many positions, which is 1/3 the number of positions Fiji requires to address the health challenge. And so the answers to NCDs, in my view, mostly exist outside the health sector. Let's just go through those in a little bit. When we talk about tobacco, yes, we can do health promotion, health education, but really the solutions exist outside in policy, regulatory, legislative changes. Taxes to tobacco is not from the Ministry of Health, it is outside of health. Decreasing advertising is an issue. When we go to alcohol, it's exactly the same thing. We talk about diet, it's a private sector that brings the food in. And if you go to the Solomons, you see shiploads of noodles going in, and that's what goes into the rural sectors. Noodles, sugar, salt, rice, flour, and these are perfect recipe. They are replacing the traditional food. And I think this is where the whole issue becomes one of what in that is health and what is private sector, what is government. And I think really my message is that governments really need to ask the question, what is the acceptable level of risk? How many people am I prepared as a government to see die before I take action? And I think really that is a challenge across the whole of the Pacific. When we come into the whole area of action, the action on NCDs, and some of these comes back to health, that we are not very good at advocating outside of health. We are not very good at getting messages across that this is everybody's business. We tend to focus on what we can do and get that in perfect unison within health, but sometimes we forget that the larger part of the solution exists outside of health. And I think if we were to have a look at this and get a much more coordinated, and now I'm talking about now a whole of government approach, that the answer to NCDs, HIV, AIDS, you name it, climate change, really needs the whole cabinet in each Pacific Island country to have one unified position to move forward. It's very difficult for one health minister to fight all the other ministers for resource allocation at the cabinet in a Pacific Island country. And this is where the roles of organizations like the SPC, WHO, in actually mainstreaming and making disciples who say, well, the private sector, the tax, the trade, you have a role to play in controlling this. And if your ministers are saying, we'd want to bring this country forward, we want economic development, but not at the cost of human life, there is a solution. And the solution will have to be a balance between what is the allowable level of expenditure to control diseases and things like taxes on tobacco. They raise resources that can be brought back into controlling some of this. So not all of that is bad. And I think really, as a final point, when we actually have a look at the future, the Pacific population, as I say, it's going to be about 15 million in 35 years from now. If we don't address this issue now, it's actually going to get worse. And I think really the policy decisions really need to be made now about approaches, because if not, the economic drain on the countries. And I think Temo is a very good example. If the father of the family, the breadwinner, is affected by the NCDs, doesn't die, they are at home, they become a burden to the family. The wife, if they work, leave work and come in and support that, their livelihood is gone. And I think it has been shown that treating NCDs well will actually help countries move to achieve the MDGs. If we don't actually address NCDs, the achievement of MDGs is going to be even more difficult to go through. Education, for instance, children out of school, poverty gets worse, the gender issues, the women not being able to look after their children. And I think really sometimes we look at this thing as a vertical area, and my key message really is NCDs is part of a gamut of health challenges that have a developmental context and needs a solution from the whole society to come in to try and address it.
Okay, Ian Anderson, if I can call on you now as our resident numbers man, what are the costs involved surrounding NCDs? Because I guess it's so much more than just the immediate cost to the health system, isn't it?
That's right. The World Bank was asked to do this particular study on the economic costs of NCDs because it's clearly a development issue in many, many ways, and it affects governments in all sorts of aspects. As we've heard before, the actual drivers of NCDs come from outside of the health system, but particularly in the Pacific, the costs actually get borne inside the health system. And in the South Pacific, that's often by governments. Governments spend most of their money for health care. And for some of the governments, this is really stretching not just their health budget, but their overall economic financial capacity to invest in development. Every dollar that you spend on a diabetes patient through a dialysis machine is another dollar that is not now going to be spent on teachers, on roads, on water supply, etc., etc. And the real problem from an economic point of view, and this is why the World Bank was brought in, some of those costs are preventable. These things can be prevented. The money can then be freed up and used for more purposes that can really generate economic growth in a sustainable way. So the World Bank was asked to look at this from a development point of view. The way we did it in the report was to break down the costs basically into sort of three sectors. There's financial costs, which is the actual money cost. There's the economic cost, what does it do to your economy? And there's the social costs. So what our studies have shown is that in the financial costs, they're very different. NCDs are very different to other diseases like diarrhoea and pneumonia and broken arms. Why? Because the costs, even though they're sometimes small, are continuous. So for example, in Vanuatu, blood glucose testing strips, the little things that you should use if you're becoming diabetes every day, costs only 43 cents per strip. Not very much. But that's $164 in the course of a year. That's more than the government is actually spending totally on health care per person. So over a 10-year period, you can see that that's really going to build up. In the case of Samoa, I looked at the cost of treating diabetes patients. It's $38,000 per patient per year. $38,000 per patient per year. That's 12 times the average national income. And 2/3 of those patients have died within 2 years. So you can imagine if you've got 10 patients in the dialysis ward, there's $380,000. The question that the governments are going to have to ask themselves is, would that money be better spent in terms of investing in other forms of healthcare which are needed, in other sectors, etc., etc.? And are these costs growing so much that they're actually threatening your economic financial viability? In Samoa, to their credit, health expenditure is the second highest item of expenditure after education. That's a good thing. That's a good thing. But if the costs of NCDs, which we've said before, are preventable, then you're really going to squeeze out your capacity to fund other things. So those are the financial costs. You can see that this is really going to have an impact in terms of the long-term sustainability and the capacity to do other things. That's the financial costs. What about the economic costs? The real problem of NCDs, I think, the evidence shows, is that it's premature deaths. People are dying younger than they should be. People are going to die of something, but in the Pacific, they're particularly dying earlier, much more so than they are on other countries at that income level. The report shows that in the Pacific, people are dying much more earlier than they should be according to that income level. In the case of Nauru, it's almost 50% of people are dying before age 65. So this is a premature loss. This is the loss of productive capacity. All of the money that has been spent on education, etc., is in a sense wasted because people are dying earlier. That's a big economic cost to a society. And there are social costs as well. 42% of women in Vanuatu die before age 65. In other words, they die prematurely. And we all know the importance of when the mother dies. It's bad enough if the father dies, but if the mother dies, there's a lot of social costs that then go through to the children and the rest of the family. They're very adversely affected if the mother dies. And if the father dies, very few of these countries in the Pacific have pension reforms or pensions that can support the family. Premature death really has big social costs for people. So for all of those reasons, that financial cost to government, the economic cost to your society in terms of its productivity, and the social costs on families, these are really important costs.
Can we touch on some of the measures that you would recommend in addressing this problem? Dr. Temo, you mentioned the best buys that the World Health Organization has identified, and Dr. Rodgers, you also touched on a few of those as well. Would you agree that governments need to restrict things like salt intake or junk food, the importation of junk food, or raise taxes on tobacco? Are you universally agreed that that is the best way forward immediately?
I think WHO and World Economic Forum, definitely. I'm sure the two gentlemen as well. Taxation on tobacco is really a good win-win situation. And it does look like the governments could potentially move in this area quickly. I mean, Cook Island have just recently increased their tobacco tax by 33%. I was having a conversation with the minister and I was asking, how did you do it? Seems like, he said, we just have a good cabinet. None of them smoke. We have a discussion. They realized the health benefits because, and tobacco taxation is great because it especially targets the youth smoking, because they are the ones who can afford the cigarette. And when you every increase in tobacco taxation ultimately results in the reduction of consumption. But you got to hit it at the right pitch, though. I think Fiji was doing a 2.53%, which does not really translate into a real behavior change in the end. So what we've encouraged them, 10% is probably the minimum. And so, and after a tobacco taxation training, the finance people kind of get the sense. We used to think it is the revenue, because you get more revenue when you increase the tax. We thought that was the best-selling argument, but it looks like the revenue guys were saying we can get revenues from somewhere else, but 1,000 lives saved, that we can't do much about, and so they move in, and so that to me is a great move, and it's one of the best buys we recommend in the tobacco area.
If I could play just devil's advocate here, because we're having a similar discussion in developed countries as well, not just in the developing countries, where say, for example, Mayor Bloomberg in New York has implemented a ban on supersized soft drinks. Denmark implemented a so-called fat tax, which has been seen to have failed. I mean, where do you sort of draw the line? Is that nanny state approach as effective as, say, creating general awareness about these good and bad foods?
I wouldn't call it a nanny state. I mean, the people who say that don't really mind then when they turn up at the hospitals expecting nanny, that is the government, to pay for all of their healthcare costs. So I reject the idea that it's necessarily a nanny state. I think what governments have got to do, I agree that they've got to raise taxes on tobacco. Not just that, I think people have got to actually implement the controls and the regulations that they've implemented. Tonga did a very clever thing, which was to survey the degree to which their rules on tobacco are actually being implemented. 2/3 of the trade stores in Tonga were still selling cigarettes by the single stick. That can be stopped by investing a little bit in those sort of issues. In terms of the taxes, prices do affect behaviour, but there's going to be limits on how far people are going to change behaviour. Changing behaviour on things like obesity, et cetera, is very hard, and so taxes are going to be helpful. It's not the only thing.
Okay, so at this point I'd like to open the floor to questions from those via video conferencing and those of us in Sydney. Can I just kick off with a question from Honiara? I don't have a name here, but this person asks Dr. Rodgers specifically, NCDs have been declared a crisis in the Pacific, but are the Pacific governments buying it? And are they convinced that it is a crisis? If so, if not, I should say, how do we get these governments to buy in that the fact that it is at crisis levels?
It's an interesting one because it's the forum leaders, i.e. heads of governments, that have declared it a crisis. The issue really is then for each of the forum leaders, the Prime Minister or the President, when they return home, to then put in place a mechanism at the political level that then gets translated down to the sector ministries and the other ministries. So I guess the first point there would be that a forum leader's declaration is meaningless unless it is actually followed through and implemented at the countries. And I think that's where due diligence and duty of care on the system that supports the leaders in the Pacific countries need to be brought to bear. I mean, I think really there's no other way. The Pacific Plan, for some of you that have heard of the Pacific Plan, is being reviewed this year and next year. And I think it's a very good opportunity because it will go back to the forum leaders. They will have another declaration of a new Pacific Plan. And learning from the lessons of what was failing in the current, it's very important that I think any further declaration that highlights things like NCDs as a priority in the Pacific really need a follow-through mechanism that actually gets it implemented at a national level. Without that, we're going to have another declaration in a few more years. I think the other thing that really is very important on NCDs is we need a mind shift. A lot of thinking on NCDs, regardless of what we're saying up here, is still very much referred to as a health problem. We need a mental transplant. That actually has NCDs as an issue that is actually driven by sectors outside of health. And I think this is why I come back to the whole issue of a cabinet. In the Pacific Island country, I've been called to some of this, and I do know how they operate. And I think it's very important. Cook Islands is a very good example where the cabinet as a whole has taken the position. Some governments in the Pacific are moving towards that, others are not. And I think really, how do we promote that? This is where the level of analysis on the cost of NCDs, what happens if they don't take action now? The answer is that it'll cost them a lot more in 10 years, 20 years, 15 years time. And I think importantly how we can assist is the World Bank, WHO, SPC and others. We can bring the evidence to bear and to say that option A, which is don't do anything, will actually cost a lot more. The legacy you leave behind is that it's a slow extermination of the population. If you, however, take a good policy decision, things like introduction of taxes at the country level, yes, you will have to go through a negotiation to try and get the right levels, noting that it's not a panacea because increase of taxes means it'll have to influence how the household expenditure runs. And if the father or whoever continues to buy cigarettes at the expense of the family food security, and you have domestic violence and other problems. So it's not that it is a panacea that it will treat everything. A solution can give rise to other things, and the important thing is to note that and have a provision for it so the tax can actually come into family education. I'm talking around the board here, but I think the key issue in summary is decision by political leaders need to be supported by implementation modalities at the country level. The country level modality needs to be across all government sectors, need to take into account the private sectors. It cannot be just Ministry of Health. And I think the way where we come in is to provide the evidence that action now and modalities of action to be taken can actually move the country forward and help take the countries with us with that information.
Okay, thank you, Doctor. Is there a question in Sydney?
Can I suggest then, I mean, for those of us who spent a long time in the Pacific, a lot of these things we look upon, I'd say in Bislama, fault below white man, it's the white man's fault. It is, we all know it. It's development, and and as the director of the museum in Tahiti said to me in 2006, and he's now dead, le développement nous tue, development is killing us. Can one, you said I have to ask a question, can I then humbly ask if the South Pacific Forum, the Melanesian Spearhead Group, the WHO, SPC, the World Bank, AUSAID, all get their act together and try and figure out what they actually mean by development, because as the medical studies done by the hospital in Noumea have shown, they were published in 1996, just before you arrived in Noumea, and they've shown, as we all know, Melanesians, and particularly Polynesians, are ethnically susceptible to rapid development of diabetes type 2 and all these other diseases if they, and this is the conclusion of the report, if they change from an active traditional lifestyle and traditional diet to an inactive Western lifestyle and Western diet. That's the basics. Tobacco has been in the Pacific for 200 years. It's modern tobacco that's creating the problems. It's not the old leaf tobacco or the stick tobacco, I have with me a chief from southern Vanuatu who's 70 years old, is as fit as anybody in this room, and he's a smoker, leaf tobacco. It's modern cigarettes that kill, not traditional stick tobacco or leaf tobacco, if it's used properly. But it's modern stuff, modern food, modern lifestyles, and everything like that. So all of these big organizations, can I say, can they all get their act together and develop a different form? Because if you're promoting a Western type of development model, you're actually, as you said, Dr. Rodgers, in a way, I'll put it strongly, are promoting a form of benign genocide for Pacific Islanders.
Okay, so are you able to frame that into a question for the panel? What would you...
Can the modern world get their act together and try and come up with a new model of development that is relevant and safe for Pacific Islanders? Please. Amen. Dr. Blumi, finish your place here. Thank you.
Take a cue from that one, I guess. Look, and I think that we were probably saying the same thing in slightly different terminology. I started off by saying 40 years ago, NCDs was not a problem in the Pacific, not as much as it now. 40 years later, it's the top killer. What changed? What made it the top killer? And I think some of the things that have changed, and here I probably have to look at another couple of things outside the health sector, and that is businesses. And with the businesses come the power of advertising. And introduce the third bit. People are no longer coming home from work and holding what we call serif in the Solomons and go and cut grass. They have a nice cup of coffee and they turn on the TV and they sit down and watch. So inactivity. And I think some of these things are behavioral. I think the whole issue that we're trying to say here is NCDs is probably at the end of the day a behavioral disease. Change behavior, it'll change. And I think some of the issues, when you ask the question, what can we do? I think part of the, I'd like to just extend that question, but part of the answer is we are doing what we should be doing, which is now bringing evidence to bear, helping governments to actually realize that if they don't do anything, it's going to cost them more. Helping governments to understand that many of the population are going to die, from NCDs more than anything else. Reprioritize development objectives. For instance, it's good to pour billions of dollars into climate change, but in the Pacific context, if everyone died from NCDs, you won't have to worry about climate change. And I think really the whole issue here becomes one of relative priorities. And then ultimately the question then is for governments, is what do governments do with the practice of private sector and advertising? Because that is the one that captures attention of the general public and children that actually then go and do these things. So I think it's got to be a double-pronged approach, where governments take the primary responsibility. I think leadership, political leadership, is the crucial thing. And then we work within that system to try and help governments to manage and navigate these options, and work with the private sector so that they can actually come in and still do the private sector things, but not at the cost of too many lives.
I agree with that too, and I would have to reject the idea that the development partners are imposing some form of sort of Western development on these countries. That's not my experience at all. These countries are sovereign, they know their forms of development, they choose what they want to do. Even if development partners wanted to impose some form of development, they just don't have the financial muscle or the capacity to do it. The development assistance for health is 1% of that goes to treating NCDs, yet it's 35 to 40% of the disease burden. There's just not enough money from development partners. You could double it and treble it, you still wouldn't be able to change the nature of these societies or health things. They can be helpful, they can be catalysts, they can pilot things, but I don't accept that development partners are somehow imposing a system that's changing the nature of these societies in that way.
If I could direct this question from PNG, this is a question from Fiona from the Child Fund in Papua New Guinea. If I could direct this question to Dr. Waqanivalu, are there best practices or approaches that countries like PNG can learn from in other developing countries, an approach that incorporates NCDs and other health programs that is workable?
Good question. Yeah, I think in the Pacific, if you look at each of the countries, they're building within themselves kind of a good practice in their own sort of setting in this range of activities for child health. I think the work that Fiji is doing lately, they've really combined a maternal child health sort of focus on breastfeeding, and Fiji is the only country in the world that have actually come up with voluntary codes as far as breast milk substitute is concerned. And then they're beginning to take that further into coming up with a bill at the moment on restricting the advertising of foods and non-alcoholic beverages to children. And at a legislative level, they've taken that across the board, and Fiji, in their political situation now, they can virtually do anything at the moment, and so they've used that opportunity. So there's a voluntary code on breast milk substitutes in terms of their maternal child health work in promoting breastfeeding, which is a measure for NCD anyway at the child health level, and they're taking that across and using that some sort of regulatory framework to bring in a legislation, a regulation on restricting the marketing of foods and non-alcoholic beverages to children. And they have this big focus, and thanks to Australia's partnership on it, on health promoting schools. So the focus on children is great in so many ways, and it's quite cost effective as well. The adults' behaviors, they're probably fixed. You can preach until the cows come home, but they're probably done. But the children, the next generation, if we don't save this one, save the next. So the schools-based programs, the health promoting school work in Fiji, they've gone to 80 schools now. with initiation. You got nice stories coming from the schools, how they've changed the canteen makeup of what they sell. They've got food gardens at the back, some real simple pragmatic stuff at that level. Coming from a high level understanding between health and education, it's probably into what Jimmie was talking about. So health and education have made a memorandum of understanding that they need to work together for the benefit and the well-being of the children. Memorandum of understanding that's kind of overarching. And so everything they want to do to focus on children is kind of a relatively easygoing because there is high-level agreement at that level. So, and this is seen in a few other countries, and it's something that PNG and others could actually learn from.
Okay, thank you. Do we have a question from Sydney? Yes, ma'am.
Thanks. Anna Dubell. In a similar vein, I was just wondering if there are any examples of good corporate responsibility where food companies have perhaps decreased the sugar content or the salt content in food that's been imported into these countries.
I think Fiji, PNG and others have food manufacturers, so those are where the potential is. And again, the flour mills of Fiji, in Fiji after the salt reduction awareness and so on, they've actually made the commitment. The thing about salt is you don't create an alternative one. You know, there's a company who made salt-free butter and no one bought it. And I didn't even buy it. Because it's the way to reduce salt is for industry to make that commitment and incrementally reduce it over time. Doesn't affect the taste, doesn't affect the profit margin, so everybody wins. And so the flour mills of Fiji have actually put in that measure, and they have 15% reduction of salt. I don't know, Jackie probably knows the detail of their noodles or bread or biscuit or something, and they've actually advertised it. And you'll see the advertisement came up, you know, the normal advertisement about their product, and at the top corner it says 15% reduction in salt content. So there's definitely some movement by the industry in Fiji to make that commitment and reduce the salt. Yeah.
And people, consumers, know what that means, why that's important, that it has 15% less salt?
Yeah, and there's a big awareness and campaign that's accompanied by the salt reduction is really three-pronged, you know. You try and do the regulation, set those standards, you know, make sure that what comes in through your port of entry has some good standards, and then you do the work with the industry and have a social marketing, strategic health communication campaign where you just let everyone know. The salt link with high blood pressure has not been as a top knowledge in the Pacific as much as sugar's link with diabetes. And so there was a bit of work that we really needed to do around the salt and high blood pressure. So yeah, coupled together with that, the reason why it needs to reduce.
This week's Economist magazine has quite a lot of, there's a special article on obesity, and there's quite a lot of information there on how the companies themselves are trying to reduce the type of foods in there. But that same article showed that total expenditure on soft drinks, sugary soft drinks, is $532 billion worldwide. Now, to put that in perspective, there's only $27 billion being spent on total healthcare from aid funds throughout the world. That means for every dollar on international healthcare, $20 is being spent worldwide on soft drinks.
In terms of corporate responsibilities, under the Food Secure framework for the Pacific, CHIPS, I think, is Center for Health Innovations here, has worked with the Food Secure Working Group, which is jointly chaired by WHO and SPC, looking at not just salt, sugar, but other micronutrients. Now, I mentioned the 5 big sins in the Pacific. Every Pacific Island country is rice, flour, sugar, salt, oil. And each of these can actually be fortified. So although we're focusing on NCDs here, it's important to think outside of NCDs into more generic whole of health approach. And I think this whole area, and this is one area where no organization in the Pacific has this expertise, CHIPS has. But they've been struggling to actually try and promote this in the Pacific. So I think this is some of the things of corporate responsibilities, and they actually working with the private sectors in Fiji, in Samoa, in Vanuatu, through the Food Secure Working Group to try and put this in. One point I'd like to just mention, because I think it's important, is relativities of resources. Because when we talk about approaches by governments, we sometimes forget the reality on the ground. Why is it that things are not moving? Take Solomon Islands, third largest country in the Pacific, population-wise, 600,000 people. They've got one NCD doctor, one coordinator, and a few nurses for 600,000 people. The recent Solomon Island budget that was passed by Parliament or still being debated is 3.2 billion Solomon dollars. For Solomons, that's a record. Translate that into Australian dollars, 600,000. The whole Solomon Island budget is smaller than the 6 months budget of the Royal Brisbane Hospital. And I think when we start to have a look at some of these realities on the ground and ask the question, why are things not working? We need to spare a thought that in many of these countries, there's probably 1, 2, 3 people trying to organize a system for the whole of the population. And sometimes it's very easy for us to make judgmental things of this country's not doing this. Look at Tuvalu, they probably have one person looking after all of that for 9,000 people. So I think it's very important as we look at solutions that we don't distance ourselves from the realities of the ground in these countries. The Pacific is 4 times the size of China in terms of area. That's quite important. And therefore, logistics, communication, transportation cost is the highest anywhere in the world. And without transportation, some of these countries basically don't have food because they rely on importation. So I think it's important as we talk about some of these issues and solutions to things like NCDs to think a little bit broader. And when we ask the question why things are not working, it also comes back to the resourcing issues and challenges that they have.
Okay, can we take another question from Sydney? Yes, ma'am.
Hello, Anne-Marie O'Keefe, Research Fellow, Lowy Institute for International Policy. My question, I think, is probably to Jimmie, but all of you may have a view. NCDs isn't just an issue for the Pacific. It's an issue for Australia and it's an issue for New Zealand. In other words, all members of the Pacific Forum. And given the significance of NCDs, is there an opportunity to actually put this on the agenda for the leaders at the Pacific Forum?
Yeah, thank you. It was on the agenda, and at the Auckland Forum last year, that's where the declaration of NCD, the Pacific is an NCD crisis. So the health ministers identified it as a crisis, went to the forum leaders last year at the forum. With that, it went to New York at the international NCD meeting. What the forum leaders are now looking at is a follow-through from implementation, but that is not coming because the forum leaders, as I mentioned earlier, needed to go back and set up mechanisms at the country level to implement and follow through. So I think the answer is yes, it will go back to the forum leaders through the Pacific Plan Review process. And I'm hoping that the Pacific Plan Review process will outline what the solutions are to actually make the declaration work.
Okay, we have a question here from Nana Yapao from Population Services International in Papua New Guinea. This is addressed to the panel. What is the best advice or solution to reduce diabetes in the Pacific?
We'll probably start there.
We need to, I think and Ian might pertain on the cost, but the primary and secondary prevention and the population-based approach versus this high-risk approach. It's the combination of this that will do the job. And let me just allude to it. The primary prevention part, which is really the healthy diet, physical activity, stop the tobacco and reduce the alcohol harm. And you've got various means and ways of doing that. A population-based approach would be to have legislation, to have policy, so taxations, policy, legislative measures. And there's some real good movement on that at the moment. Now that takes care of preventing them from getting diabetes in the first place. Yeah? What is also needed is secondary prevention, whereby for those who are almost there, okay, pre-diabetic sometimes we call, and for those who are having diabetes to have secondary prevention. And the high-risk approach compared to the population is you identify those who are really at the high risk end of things. Because you can continue the promotion of lifestyle and the primary prevention and so on, but the fact of the matter is there's already too many going down that river already. And instead of just going further back and try and address the primary and the primordial sort of issues, we need to kind of intervene midstream to that proportion of the population that are almost at the edge of the cliff, more or less. So not just the fence here, but also at the edge of the cliff, can we actually come in and address that? And not just for diabetes, because if you really look at diabetes, it's kind of we still kind of label it as an intermediate risk factors, because you are absolutely okay. You're feeling there's no symptoms at all until the nurse pricks your finger, gets a blood dropped into the meter, compares with some international classification, and then welcomes you to the club. So in a way, it's still an intermediate risk factor in that sense. The focus now that we are trying to introduce to the Pacific through the package of essential NCD interventions is to actually look at the total risk in terms of the ultimate outcome. When you look at it, there's three things that's going to cause premature death for these individuals. They'll either have a stroke, or they'll have a heart disease, or they'll have chronic renal failure. And so one of the changes in approach we're bringing to the Pacific is what we call the package of essential NCD services, whereby your whole intention, objective is to prevent or delay those outcomes because of the economic implications, because of and so on. And instead of focusing on one risk factor, which is diabetes, high blood pressure, high cholesterol, which seems to be the mode of addressing it at the moment, you kind of look at that in totality and figure out what is the risk of getting a cardiovascular disease in the next 10 years. Because the fact of the matter is, low and middle income countries, there's just no way you can try and treat and control every diabetic and everyone with high blood pressure or high cholesterol, given the magnitude of the problem. There's just no way. The NCD STEPS surveys we've done, we've come out with figures that despite all the great work health is doing, 70% of diabetics still undiagnosed, let alone treat and control. So that's a major change we're bringing to the Pacific as well in this package, where you're saying you don't just look at diabetes and you say, welcome to the club, this is what you need to do. You're kind of saying, you've got this sugar level, this pressure level, and all of this, and as such, your risk of developing a cardiovascular event in the next 10 years is 30%, and you manage that risk accordingly. So you take care of those that really are not there, but you also focus in on those who are almost at the edge of the cliff and intervene, because those are the ones that's going to end up in the accident and emergency one of these days and continue in that process. So it's that combination.
We'll take one last question from the floor, and perhaps our panellists can give us their final thoughts in that as well. The gentleman here.
Richard Taylor from University of New South Wales. And as Jimmie mentioned, past SPC epidemiologist. I just wanted to ask the rhetorical question, since I have to ask questions, about whether the relative focus on young children versus adults, particularly in view of the experience, which has not really been touched on here, and there's no time to do it, but the experience of tremendous reduction in premature mortality in many developed countries, and not due to them all getting cardiac bypass, coronary artery disease surgery, but actually changes in diet, changes in smoking. I mean, there are enormous successes we can point to. But you just made a mention about children, because I'm aware of these hypotheses of causation of coronary heart disease 50 years later, which the health economists would do if they did future discounting. There wouldn't be a lot of things left. But I just wondered that, because the experience in Australia was that the mortality dropped in all ages simultaneously in adults.
It wasn't a birth cohort effect. It was in all ages. And I just wonder whether we can get a balance between not throwing away the present generation, which I've heard stated in relation to Indigenous Australians as well. That is the present generation of adults, and just focusing on the next generation. One also wonders whether the next generation will grow up any different if you don't change their parents.
All right, if I can just mention, and again, this is where the package of essential NCD services, cardiovascular disease access in terms of treatment and counselling. The history from the developing countries, including Australia, the reason why the mortality, 50% of that is actually attributable to the focus on the high risk end and not just the population widely. So I just wanted to throw that in. That's actually coming from that history with the developed world, developed countries in particular, that just focusing on primary, and the primordial sort of things and the healthy lifestyle did not do the job until you zero in as well on the high risk group. That's where really the evidence behind WHO promoting that in the countries. So it's 50% of that reduction is attributable to the intense high-risk approach instead of just the population-based ones.
I'd just like to sort of comment on that earlier one about diabetes. We did, for the World Bank study, we estimated the cost of diabetes as it progresses in Vanuatu. Just very roughly, if the Vanuatu government, through its primary health care system, through lifestyle changes, etc., stops one person acquiring diabetes, then the government has saved roughly $350 per person per year. That's about 3 times what they're currently spending already on healthcare. Now, 3 people's healthcare spending is saved by that. If that person then, through secondary prevention, doesn't go to insulin, they'll probably save another $500 per person per year. So that's $850 will be saved every single person per year that you can avoid getting through to diabetes. That's around 8 times what people are currently spending on healthcare more generally. These are enormous savings. And you can do it through this early primary level prevention and secondary prevention. It can be done at the lower cost through the rural healthcare system, and that's going to be more equitable. And the other part that's a very good investment in answering that question from the lady from Papua New Guinea, investing in women also is a very good investment, not just for the woman's own health, but in terms of transmitting diabetes through to the next generation. We can interrupt that problem through to the next generation.
Dr. Rodgers with the final thought.
Okay, so the question from the lady from PNG, very good question, and I think some responses to it. But more often than not, it's very easy for us to talk about somebody else. And it's very difficult to reflect back on ourselves. And I think NCDs is one where we need to ask the question individually to ourselves. How do I need to change if I don't want to die from NCDs? And I think really I'm saying there that the best approaches will need to be behavioral change, either individually. So I ask myself the question, what is it I'm doing that if I continue to do, I'm committing suicide and therefore I need to change? And the other is then targeting to the government policy system where it takes a broader arrangement that involves private sector and others. But the final question from Richard on this whole issue of balance between current and future generations. I think for me the question really is, what legacy does the current generation of decision makers leave behind for future generations? And I think the whole issue there becomes one of history. Shows, I think it's Thomas McEwen from Australia, that actually in a book that he wrote, that the 6 things that have made great contribution to health were education, water, sanitation, nutrition, housing and environment. And pour money into those, health looks after itself. And I think much of history has also looked at that. If we were to look at the 10 things that have made the huge impact on health of late, I think the CDC, only 2 or 3 of those were health. most of them were outside of health. And I think it's very important that we don't lose sight of the fact, as we look at in-health solutions, that much of what we're looking at is probably outside of health, therefore the need to generate support from outside of the governments. And I think it's very important that we focus on children because they're the up and coming and invest as much as we can in changing the behaviors of existing adults, because I'd rather we leave behind an epitaph, here lies the person that invested in the future of the children, than an epitaph that says, here lies the person that dragged himself to death. Thank you.
Thank you, Dr. Rodgers. And that sadly brings us to the end of our discussions. Apologies to everyone in Sydney and from afar that we didn't get to your questions, but hopefully you'll be able to bail up these gentlemen individually with your questions. But can we please thank our panellists, Ian Anderson, Dr. Jimmie Rodgers and Dr. Temo Waqanivalu. And I'd like to thank everyone joining us either here in Sydney or from afar. And remember, you can view this or any of the other Praxis discussions at the website worldbank.org/Praxis. Now, we'll be back next year with a new round of discussions. Until then, I'm Auskar Surbakti, and thanks for joining us.